This is ABSITE and Board review for colon and rectum. The appendix and cecum is addressed in another video, so be sure to check that one out as it covers things like appendiceal tumors, cecal volvulus, Ogilvie's, and other things. As always, let's start with anatomy. The colon is the ascending, transverse, descending, sigmoid, and then the rectum. The colon has three Tenia coli that are separate bands which at the recto-sigmoid junction transition to circumferential muscle that surrounds the rectum. Most of the rectum is extraperitoneal. The peritoneal reflection anteriorly is the pouch of Douglas. This is lower in women, and the Denonvillier's fascia is the layer between the vagina in women and the prostate and the rectum in men. The Waldeyer's fascia is the rectosacral fascia posterior. The food supply of colonocytes is short-chain fatty acids. The colon secretes potassium and bicarbonate, and it absorbs water and chloride. Diarrhea leads to hypokalemic metabolic acidosis. The blood supply to the right and proximal transverse colon is from the ileocolic and the right and middle colic vessels coming from the SMA. The left colon is supplied by the IMA, directly from the aorta. The classic watershed area is at the splenic flexure at Griffith's Point, as the blood supply to this area is from the marginal artery of Drummond, that is a collateral between the middle colic and the IMA, that runs distal in the mesentery near the colon wall, whereas the arc of Riolan is a collateral that runs closer to the root of the mesentery. The other point prone to ischemia is at the recto-sigmoid junction at Sudek's Point. The anal canal is the first 4 centimeters or so above the anal verge. Then past the dentate line, the rectum is divided into 3 sections. The lower rectum is 0 to 5 centimeters from the levators. The middle rectum is 5 to 10 centimeters from the levators. And the upper rectum is 10 to 15 centimeters from the levators. The distances vary depending on a person's height. 3 to 4 folds of the mucosa in the rectal lumen are called the valves of Houston. The upper rectum gets blood flow from superior hemorrhoidal artery, which is a branch of the IMA. The middle and lower rectum gets blood supply from the internal iliac artery, and the middle and inferior hemorrhoidal arteries. The lymph node drainage from the upper rectum is to the base of the IMA and the periaortic nodes. The middle rectum can also drain to the IMA, but also to the internal iliac lymph nodes. The lower rectum and anal canal can drain to the IMA, iliac, as well as the inguinal lymph nodes. Venous drainage from the superior and middle rectal vein goes to the IMV and eventually to the pleural vein. The lower rectum vein drains into the internal iliac vein. Sigmoid volvulus is when an elongated sigmoid on a long mesentery twists on itself. It's more common in the elderly, those with chronic constipation, neurologic or psychologic disease. KUB finding is bent inner tube or coffee bean sign pointing to the right upper quadrant. If not septic or has peritonitis, try flexible or rigid sigmoidoscopy to detorse and then leave a rectal tube. Then prep the colon and try to do an elective sigmoid resection during the same hospital stay due to a high recurrence risk. If you cannot detorse or the patient already has ischemia or peritonitis, then take to the OR for sigmoid resection and end proximal colostomy. Diverticular disease is caused by false diverticulum. These only contain mucosa and serosa. There is no submucosa, so they are false and are less strong than native bowel wall. They tend to occur in the sigmoid colon and at the point of the vasa recta, penetration through the natural weak spots in the muscularis as they go to the mucosa. Since the diverticulum is near the blood vessels penetrating the bowel wall, they are prone to arterial bleeding. The 3 complications of diverticular disease are bleeding, obstruction, and infection. Lower GI bleeding has bright red blood per rectum, but you should rule out a brisk upper GI bleed with an NG tube and gastric lavage. But if this is normal, then focus on the colon. The most common cause of lower GI bleed is diverticular disease, but others are tumors, angiodysplasia, or ischemia. In general, always start with a colonoscopy, since if you can find the source, it is also therapeutic via epinephrine injection, cautery, or clips. If a colonoscopy cannot find the source, then you should try a tagged RBC bleeding scan that detects bleeding up to 0.5 milliliters per minute. Or if there is brisk bleeding, you could use an angiogram, which can detect bleeding at a minimum of about 1 milliliter per minute. Angiogram localization may allow for focused vasopressin infusion or embolization. If you have localized the area, but the above measures don't work, and you have transfused more than 4 units of packed red blood cells, then you should resect this segment of colon with an endostomy. If you can't even localize the location of the bleeding, but you are confident it is somewhere in the colon, then you should do a subtotal colectomy with an endoileostomy. Obstruction of the colon from scarring due to diverticulitis should get a colonoscopy to biopsy and rule out cancer and possibly stent it open. Usually this ends up being treated with resection, hopefully after a prep with primary reconnection. But obviously if somebody is acutely obstructed, also do a resection and an end colostomy, known as a Hartmann's procedure. Lastly, diverticulitis is infection of the diseased segment of colon. The Hinche classification is a common question. Hinche 1A is segmental inflammation or a phlegmon. This is treated with antibiotics and bowel rest. Hinche 1B includes a small pericolic abscess that usually does not need IR drainage and also gets antibiotics and bowel rest. Hinche 2 is an abscess that is large enough to do an IR drain and usually is located in the pelvis. A Hinche 3 is purulent peritonitis, and Hinche 4 is fecal peritonitis. Hinches 3 and 4 go right to surgery after resuscitation. In general, you should start your career by answering that you would do a Hartmann's procedure for these, which is resection of the diseased area, end colostomy, and mark the rectal stump with a long Prolene stitch. Then you would consider reversal after 6 weeks at least, and only after a colonoscopy is done through the proximal stoma. Sure, there are other techniques such as resection, anastomosis, and diverting loop ileostomy, but I would be cautious about using these less aggressive approaches. Chronic diverticulitis is an area of debate. It's probably safe to say that you would consider elective colon resection after 4 episodes of documented uncomplicated diverticulitis, or fewer if complicated by things such as abscesses or fistulas. Colovesicular fistula is more common in men since women have a uterus between the colon and bladder protecting it. If you have a colovesicular fistula, the patient will present with air and stool in the urine, air in the bladder on imaging, and recurrent urinary tract infections. Rule out cancer with endoscopy. Surgery for this is resection with repair of the bladder hole. You can use methylene blue through the Foley if you can't find the hole, and then place an omental flap between the colon staple line and the bladder to protect the repair. Ischemic colitis is commonly seen on tests after aortic surgery with ligation of the IMA, or in low flow states such as in hypotension. Remember that most of the blood flow to the colon goes to the mucosa, so that is the first place to show ischemic changes. If somebody has a bloody bowel movement with abdominal pain, status post AAA repair, then the best diagnostic test is a colonoscopy to look at the mucosa. The splenic flexure, or Griffith's point, is particularly at risk. If just superficial mucosa is ischemic, try bowel rest, IV fluids, and antibiotics. If the mucosa is black and full thickness ischemia or clinical deterioration, these patients need surgery for a resection and ostomy. Pseudomembranous colitis is from C. difficile. Profuse watery diarrhea with abdominal pain and cramping with fevers and usually an impressive leukocytosis are classic signs. Test with PCR for C. diff toxin B gene in the stool. Treat with oral vancomycin if severe. Oral or IV flagyl works less well but okay for mild infection. You can get toxic megacolon and need a subtotal colectomy with endoileostomy. Inflammatory bowel disease, Crohn's and ulcerative colitis will be tested. There is actually a lot of overlap in symptoms and treatments between the two in real life, but for testing purposes, they try to keep them split when it comes to certain criteria. Crohn's can affect the entire GI tract from mouth to anus. Classic presentations are aphthous ulcers in the mouth, new onset of perianal fistulas, or lateral fissures in a younger person, systemic symptoms such as uveitis, arthritis, ankylosing spondylitis. Crohn's spares the rectum usually, as opposed to ulcerative colitis that usually involves the rectum. Crohn's can have skip lesions, but ulcerative colitis moves confluently from the rectum proximally without skip lesions. Crohn's has transmural inflammation, non-caseating granulomas, creeping fat, and cobblestoned mucosa. Ulcerative colitis has crypt abscesses. Crohn's strictures are treated with stricturoplasty when possible. Ulcerative colitis does not involve the anus and is more associated with bloody diarrhea. Ulcerative colitis is more linked to sclerosing cholangitis. Sclerosing cholangitis does not get better even after the colon is removed. Ulcerative colitis can lead to a higher risk of colon cancer. You should screen with colonoscopy annually after 10 years of disease and do a total proctocolectomy if any high-grade dysplasia or cancer is found on screening. With ulcerative colitis, you can do an ileal pouch anal anastomosis, or IPAA. You cannot do this with Crohn's disease, since the ileum tends to make fistulas, so you wouldn't want to use it for an anastomosis to the rectum. We talked about treatment in the small bowel video, but to recap, medical treatment of both ulcerative colitis and Crohn's is divided into drugs for acute flares and those for maintenance therapy. Treatment of flares is with steroids. Steroids should be weaned or stopped if able after the flare cools off. Aminosalicylates like sulfasalazine or 5-ASA can help by decreasing inflammation and are used for maintenance. Immune suppressants like azathioprine or cyclosporin are often used for long-term maintenance. Infliximab or Remicade is a monoclonal antibody against tumor necrosis factor. It is used for steroid refractory flares and specifically to help close Crohn's fistulas. Be sure to know about toxic megacolon, as this is more associated with ulcerative colitis. The classic presentation is abdominal pain, bloody stools, fevers, sepsis, and a dilated transverse colon with loss of haustral markings. You should start treatment with fluids, steroids, and antibiotics such as Cipro and Flagyl. Do not give anti-diarrhea medicine like Imodium. If not responding to conservative measures, go ahead and do a total proctocolectomy with endoleostomy. Save the IPAA for future surgery. Let's talk about colon and rectal polyps. Pedunculated means it looks like a mushroom, and sessile means it's flat like a carpet. This is a morphologic description, not a pathology type. Hyperplastic polyps are benign on pathology. Serrated adenomas are also premalignant and need a full colonoscopic removal. The majority of premalignant polyps, though, are called adenomas. We think that colon cancer develops from adenomatous polyps over years. APC gene mutations occur early on, and DCC or deleted in colon cancer gene mutations occur late in the polyp to carcinoma sequence. The three kinds of adenomatous polyps are tubular, tubulovillous, and villous. Tubular adenomas' risk of becoming cancer is probably less than 10%, and they tend to be pedunculated, and colonoscopic polypectomy is usually sufficient. A villous adenoma, however, has at least a 25% chance of turning into cancer. These tend to be sessile, larger, and harder to remove endoscopically. A tubulovillous adenoma risk is between the other two, but usually treatment is clumped in the same as a villous adenoma. A large villous adenoma of the rectum can also cause secretory diarrhea and electrolyte loss, classically hyponatremia and hypokalemia. The way the question is often structured is if you find a polyp on colonoscopy, to which you would answer hot snare if pedunculated, or biopsy alone if villus and too large to snare. If a pedunculated polyp contains cancer, then you use the Haggett classification to see if you need to actually do surgery or if the polypectomy alone was sufficient. Haggett 0 means there is carcinoma in situ of the head of the polyp and polypectomy alone is sufficient. Haggett 1 is invasive adenocarcinoma in the head of the polyp, and usually a polypectomy through the stalk of the polyp is sufficient. Haggett 2 is invasion of the junction between the head and the stalk, and if you have a greater than 2 millimeter margin from the polypectomy, then no further surgery is usually needed. Haggett 3 is invasion of the stalk of the polyp, and again, if you have greater than 2 millimeter margins and no lymphovascular invasion, then polypectomy alone should be sufficient. A Haggett 4 means it has invaded the submucosa of the actual bowel wall, which would likely also have a positive deep margin anyway on a simple polypectomy. So Haggett 4s will need a segmental colon resection surgery with lymphadenectomy. All sessile polyps, which would usually be tubulovillus or villus, with cancer especially, would get a segmental resection. A large sessile tubulovillus or villus adenoma that can't be removed endoscopically, regardless of whether it has dysplasia or cancer already, still needs surgical resection due to future cancer risk. Colorectal cancer is the third most common cancer in the United States. Risks include a diet high in red meat, obesity, alcohol use, and smoking. The most common locations for colon cancer are 25% in the ascending colon, 25% in the sigmoid, and 25% in the rectum. The remaining 25% of colon cancers are spread throughout the transverse and descending colon. Screening should be a colonoscopy every 10 years starting at age 45, or annual fecal occult blood testing with FIT testing, and sigmoidoscopy every 5 years. As we just learned that 50% of cancer is in the rectum or sigmoid, so you could at least see those, although it's best still to do a full colonoscopy if you can. Once colon or rectal cancer is diagnosed, CT chest, abdomen, pelvis, and serum CEA is sufficient staging, since the liver is number 1 site of metastasis and lung is number 2. Drop metastasis to the ovary is common and are called Krukenberg tumors. Remove the ovaries prophylactically in postmenopausal women is not a bad idea. The T stages for colon and rectal cancer are essentially the same. T1 cancer involves the submucosa. T2 involves the muscularis propria. T3 is through the muscularis into the subserosa of the colon or the perirectal tissue since the rectum lacks serosa. T4 is a perforated or a tumor that invades the peritoneum of the abdomen or into other organs. N1 is 1 to 3 involved lymph nodes. N2 is 4 or more involved lymph nodes. Stage 3 is any node that's involved. Colon cancer is removed based on anatomic location. Cecal and right colon cancers get a right hemicolectomy with ligation of the right colic and the ileocolic arteries low down, so good lymph node count of at least 12 is obtained. A hepatic flexure or proximal transverse colon cancer is usually treated with an extended right hemicolectomy, in which the right colon and proximal transverse colon are removed and the ileum reanastomosed to the distal transverse colon. This often requires ligation of portions of the middle colic artery also. A distal transverse colon cancer can be removed with just a segmental resection. In the descending and sigmoid, just a segmental resection with reanastomosis usually works. We will talk about rectal cancer surgery shortly. About 20% of people have a competent ileocecal valve, meaning that a colon obstruction cannot decompress into the small bowel, so they can act like a closed loop obstruction and can perforate, usually at the cecum. Remember that the cecum is the most likely place in the colon to perforate, since it has the largest diameter, and the law of Laplace says that higher wall tension is equal to a larger diameter. If an obstructing sigmoid colon cancer causes cecal perforation, then you should do a subtotal colectomy, probably first with an ileostomy, and later do a reconnection. If a high rectal or sigmoid colon cancer presents with obstruction without perforation and no metastatic disease, try placing an endoscopic colon stent, then prep and try to resect without needing an ostomy. If unable to place a stent and prep, then they will need a Hartmann's with a colostomy. Chemotherapy is given for node-positive patients who are automatically stage 3 by definition. A few high-risk situations, such as perforated tumors or obstructing tumors, or a low lymph node removal at surgery of less than 12, are also considered for chemotherapy, sometimes regardless of lymph node status. Chemotherapy is classically FOLFOX, which stands for 5-FU, leucovorin, and oxaliplatin. CAPOX is capecitabine and oxaliplatin. Rectal cancer is treated very differently. So first, it is important to know what defines rectal cancer. The rectum is roughly 15 centimeters long. The lower rectum is 0 to 5 centimeters from the levators, middle's 5 to 10 centimeters, and the upper is about 10 to 15 centimeters from the levators. If you find a tumor on colonoscopy that is less than 15 centimeters from the anal verge, it is probably going to be classified as a rectal cancer. The other technical definition is the rectum is below the peritoneal reflection, which is lower in a woman, especially if they are short. So doing a pelvic MRI to see if the tumor is extraperitoneal in the soft tissue of the pelvis will confirm that it is rectal. Once a tumor is considered to be in the extraperitoneal rectal area, then we consider chemoradiation prior to surgery. Chemoradiation is given to T3 or more, so essentially any tumor that is penetrating through the muscularis propria or any node-positive tumor. The T and N staging is usually from a pelvic MRI now, but it could also be from an endorectal ultrasound. Neoadjuvant chemoradiation is usually 4 weeks of radiation at about 4,500 centigrade, with some radiation sensitizing chemotherapy at the same time. This is not full dose FOLFOX, by the way. It's usually just something like 5-FU alone. Giving full chemotherapy and radiation together is too toxic. After the long course chemoradiation of 4 weeks, then we wait 6 to 10 weeks to restage, which is a proctoscopy and maybe an MRI again. Then you should do the surgery, waiting that period of time for the tissue to recover. 15% of tumors will completely disappear or have a complete pathologic response with chemoradiation. But for testing purposes, you should still offer those people curative surgery, same as everybody else. If you can get a distal margin of 2 centimeters and spare the sphincter muscles, then you can do a LAR or a low anterior resection. This would correspond to at least 6 centimeters from the anal verge, since about 4 centimeters of this is the sphincter muscles themselves. General protocol is to do a diverting loop ileostomy when you do an LAR post-radiation or with a low anastomosis. Any tumor lower than 5 centimeters from the anal verge is probably going to need an APR. APR, or abdominoperineal resection, is removal of the rectum and anus with closure of the perineum and an end colostomy. Perineal wound breakdown after an APR, especially after radiation, will need a muscle flap such as a gracilis flap to heal. Maybe you should even do that prophylactically if the patient has been previously radiated. Chemotherapy is given after surgery usually, and it is given to patients who had stage 3 disease prior to chemoradiation, even if they had a good response. Even a complete pathologic response, meaning there is no cancer left in the rectum. So chemotherapy decisions are based on pre-treatment staging. Total neoadjuvant therapy, or TNT, is when chemotherapy is given first, followed by chemoradiation, then finally surgery. This is not standard of care yet, but it's commonly discussed now for large tumors of the rectum. Let's talk about transanal excision. This is when something is removed through the anal opening, and usually you should take 1 centimeter margins around it, and the entire wall of the rectum is removed down to the perirectal fat, and then the defect is sutured closed. It is used for large rectal polyps with dysplasia, or very early T1 rectal cancer. I would not use it for T2 tumors on a test. It has to be reachable from the anal opening, so probably 8 centimeters or lower from the anal verge. It should be less than 4 centimeters in size, and the tumor should be less than 1/3 of the circumference of the rectal wall, and there should be no high-grade features or lymphovascular invasion. Let's talk about genetic syndromes associated with colon and rectal cancer. Lynch syndrome is the same as hereditary non-polyposis colorectal cancer syndrome, or HNPCC. So DNA bases match A and T and G and C, and sometimes during DNA replication a mismatch occurs, say A to C. This mistake is repaired by DNA mismatch repair proteins. The two most commonly affected are MLH1 and MSH2. If mismatched DNA is replicated again, the new daughter strands in 2 different cells will be different. Certain areas in your DNA have sequences such as AG, and these are actually normal, and these repeated areas are called microsatellites. If you have problems with mismatch repair proteins, then you get different number of microsatellites within the same tumor tissue compared to normal tissue. This is what microsatellite instability, or MSI high, is actually referring to. This is tested for in 2 ways. One is to do immunostains for the actual proteins like MLH1 and MSH2. The other is to do PCR of tumor tissue versus normal colon tissue and compare the two, looking at a specific microsatellite area called a loci. Colon cancer tissue will have different microsatellite counts on PCR as compared to normal colon tissue from the same person. So this would be showing a MSI high colon cancer. About 15% of all colon cancers are MSI high, but only about 1/3 of this, or about 5% of all colon cancer, is due to germline mutation in the repair genes, which is what Lynch syndrome actually is. The other 2/3 of MSI high tumors are from somatic mutations of the mismatch repair proteins. This is technically not Lynch syndrome since you don't inherit it. So to recap, not all MSI high colon cancer means that you have Lynch syndrome. Sorry, I know it is confusing, but you'll look really smart at Tumor Board if you know that. If you're known to have Lynch syndrome, you get every 1 to 2 years screening colonoscopy, and if dysplasia or cancer is found, you get a total colectomy with an ileal pouch anal anastomosis, or the IPAA. If you have Lynch syndrome, you can have endometrial cancer, ovarian cancer, and stomach cancer, higher risks. So do screening endoscopy, and hysterectomies are often done in women. There was a criteria called the Amsterdam criteria that was a quick rule of thumb way to decide who needed screening for Lynch syndrome. This was known as the 3-2-1. 3 first-degree relatives with colon cancer, 2 successive generations of colon cancer, and 1 of those persons with colon cancer less than 50 years of age. The other big one is FAP, or familial adenomatous polyposis. This is caused by an APC gene mutation on chromosome 5. About 80% of these are inherited, but 20% are actually somatic mutations. These patients have thousands of colon polyps and get early colon cancer. In contradistinction to Lynch syndrome, FAP patients with high polyp counts need prophylactic proctocolectomy with rectal mucosectomy and IPAA when they are diagnosed or in their early 20s, since screening is nearly impossible due to the innumerable polyps. FAP with bone tumors is called Gardner syndrome, and FAP with brain tumors is called Turcot syndrome. Well, that's probably enough for now. There is a separate video coming for anal diseases specifically, so check that one out. I hope that helped, and good luck.